Hello all, welcome to Pharmanandan. This is a new module. In this module, we are going to discuss central nervous system. The first topic is antidepressants and anxiolytic drugs. This is the first video in this topic. Okay, let us dive into the topic. So before studying antidepressants and anxiolytics, we need to know a common point. A single point is, for example, take a person who is very sad. He is diagnosed as a depression patient. He has depression. The thing is, this patient is often associated with anxiety also. And that is the reason common group of drugs share together both the actions, antidepressant action and anxiolytic action, with some differences. Okay, so better to study both of these topics simultaneously. Coming to the major depression, where do we see major depression among males or females, in whom we see 2x will be the difference? Yes, females have more incidence of depression cases than males, than 2 times. The problem with this depression is, with respect to society, depression is a disease often underdiagnosed and undertreated. What happens actually in depression, that is pathophysiology, we don't know the exact pathophysiology. We have a old hypothesis which is most believed hypothesis, because while we are doing some experiments on lower animals and even on humans, we came to know that serotonin is often associated with mood. This is old hypothesis which is believed widely. Based on this, most of the drugs are developed for depression and anxiety. And we observed that norepinephrine is often associated with cognition. And we found that when there is less activity of serotonin, we found less mood in a patient. When there is less activity of norepinephrine, less cognition in that patient. Not the same, it differs. Okay, not in all the cases. What is there in depression? Yes, we know in depression we can see the patient has less mood and less cognition levels. Then we associated this low activity of serotonin and low activity of norepinephrine to depression, and we started synthesizing drugs which can increase the activity of serotonin and increase the activity of norepinephrine. And one more theory came into the force, that is brain derived neurotrophic factors. This is the latest hypothesis. This is latest hypothesis, and we came to know that this brain derived neurotrophic factor is associated with the plasticity of the neurons. And when there is less activity of this brain derived neurotrophic factors, less expression of these brain derived neurotrophic factors, we find it is associated with depression. And on further studies, we came to know that lower expression of brain derived neurotrophic factors is associated with lower activity of serotonin and norepinephrine. If we go deep into the neurons, let us say this is a serotonergic neuron. Okay, this is presynaptic, this is postsynaptic neuron. Okay, serotonin is here, it is released into the synaptic cleft. Serotonin is released into synaptic cleft. This serotonin keeps on working here on the receptors until it is present in the synaptic cleft. It should be reuptake into the presynaptic neuron. How it is reuptake? Because of a transporter. The transporter we call it as neuronal serotonin transporter. So if we could inhibit this transporter, what happens? There will be no reuptake. More and more serotonin will be available here. Okay, same theory occurs with the case of norepinephrine also. Let us say this is norepinephrine neuron. Okay, norepinephrine is released from presynaptic neuron. It is inside this synaptic cleft now. It keeps on working here on the postsynaptic neuron receptors until it is present in the synaptic cleft. It should be taken back into presynaptic cleft. Same theory, but the channel differs, the transporter differs. What is the transporter for this? Neuronal norepinephrine transporter. And if I block this transporter, what happens? There will be no reuptake, more and more availability of norepinephrine in the synaptic cleft. So the common thing is, with respect to serotonin and norepinephrine, we are trying to increase the norepinephrine level or serotonin level in the synaptic cleft so that there will be more activity, thereby we can treat depression disease. Is there any other method to increase this norepinephrine activity and serotonin activity? Yes, norepinephrine and serotonin has metabolism pathway. Who metabolizes them? Yes, monoamine oxidase enzyme. What are monoamines? This norepinephrine, these histamines, and this serotonin and dopamine, all these come under monoamines. If I could inhibit the monoamine oxidase enzymes here, eventually there will be more and more levels of serotonin and norepinephrine levels in the synapse. Thereby we can treat the depression. What comes under the treatment of depression? Is pharmacotherapy is the mainstay treatment of depression? No. To treat depression along with pharmacotherapy, there are many other domains. What are those? Pharmacotherapy plus counseling. Counseling consists of many things. One important thing among them is cognitive behavioral therapy and lifestyle modifications, which includes diet, physical exercise, and many other things. In this topic, we are discussing only pharmacotherapy. Okay, for pharmacotherapy, what are the agents we use for depression? There are two generations. The first generation of antidepressants consists of TCAs, tricyclic antidepressants, and the second one is monoamine oxidase inhibitors. Monoamine oxidase inhibitors. The second generation antidepressants consists of selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors and atypical antidepressants. All these together comes under second generation antidepressants. In this video we are going to discuss only tricyclic antidepressants. These tricyclic antidepressants are of two types based on chemical structure: secondary amine TCAs and tertiary amine TCAs. What comes under secondary amine TCAs? Yes, desipramine, maprotilin, nortriptyline, protriptyline, and amoxicillin. What comes under tertiary TCAs? Amitriptyline, very important drug for side effect. Many questions are asked based on this amitriptyline drug. And clomipramine, and doxepin, imipramine, and trimipramine. So what is the main difference between these two? What happens with secondary amine TCAs and what happens in tertiary amine TCAs? The name itself will tell you. It has smaller structure, it has a wider structure. Okay, this wider structure has more moieties, it can block more types of receptor, it has more more umbrella of receptor types. Okay, the main difference is these secondary amine TCAs, these block norepinephrine transporters. These tertiary amine TCAs, these block norepinephrine transporters, along with it, yes, serotonin reuptake transporters also. Here there is only one transporter blocked here. In these two types of transporters are blocked here. So it is the main difference. Apart from it, TCAs has one more property of blocking some other transporters also. Apart from this transporter, it will block some receptors also. What are those additional receptors? All the TCAs do not block all the following receptors. It is selective based upon the drug. What are the receptors they can block? Yes, they can block dopamine receptors, they can block serotonin type 2A receptors, they can block alpha 1 receptors, they can block first type of histamine receptor, histamine type 1 receptors, and they can block muscarinic type of receptors also. And these receptors are blocked based upon the drug moiety. All the receptors are not blocked. It is depending upon the drug type. Understood? So this is the one which decides the side effect of these TCAs. For example, let us say this take amoxapine. This amoxapine has dopamine receptor blocking property. What happens because of this? We can see extrapyramidal symptoms when this amoxapine is taken. Additionally, along with this norepinephrine transporter blockade, dopamine receptor is also blocked. We can see extrapyramidal side effects like tardive dyskinesia. In these patients, whoever take amoxapine, we can expect these things. One more example is important drug, as I told earlier, amitriptyline. Amitriptyline has pronounced anticholinergic property. Pronounced anticholinergic property. It causes toxicity. We will discuss in further slides. And one more thing it causes is QT interval prolongation. This is very important when we discuss toxicity of TCAs. Okay, these are two examples to make you know to let you know how these different types of receptors blockade will cause us a spectrum of side effects in TCA. Coming to the uses of TCAs, we know TCAs come under first generation and they have more side effect profile, and most of them are almost similar in efficacy, but there are difference, but they act different with respect to side effects. Okay, and where these TCAs are used, it depends upon the dose. Two types of uses we know. When it is given in therapeutic doses, it is given in therapeutic doses only in patients who are having severe depression, not in mild to moderate depression. Even in severe depression these days we are trying to avoid this one. Only in severe depression patients who have these trouble some features complaints like insomnia or excessive psychosis, because this side effect profile will act on this insomnia and they will decrease psychosis also, right? That's why we prefer, we keep these TCAs as reserve drug for severe depression cases. Okay, apart from therapeutic doses, we have another use of TCAs when we give them in low doses. When do we give them in low doses? In a variety of pain conditions, like example neuropathic pains, okay, and insomnia without depression. If a patient has insomnia but no depression, TCAs are used in low doses. Like examples we can say amitriptyline, it is used for insomnia without depression, and doxepin is also used in insomnia without depression. Okay, what is the side effects of these TCAs? Before discussing side effect, yes, we mentioned earlier, right? Depends upon the type of receptor which they are going to block. These side effects, what are the side effects of the TCAs? These side effects of TCAs, the first thing we should know is it can lower the threshold to the seizure point in a patient. If a patient is not active epileptic patient, but he may land in seizures, because this threshold to get epilepsy is decreased by TCAs. Not only TCAs, all the major group of antidepressants have this property of lowering seizures. And coming to the serious side effects, what are the serious side effects among which we should bother when we prescribe TCAs? We mentioned earlier, this side effect depends upon the receptors on which these drugs are blocking. Okay, let us note the receptor type and the side effect which causes by the blockade of this receptor. This blockage and side effect profile we will write here. Let us say if H1 receptors or histamine type 1 receptors are blocked, what is the side effect we can expect? Sedation, excessive sedation in a patient. If muscarinic receptors are blocked, what can we expect? There will be a decline in cognition of a patient. Okay, what are the other things which can be expected in a patient? Yes, vision will be blurred and dry mouth can be expected, and mydriasis may be expected, and tachycardia will be expected. Bradycardia is also expected in another situation which I will tell you later, and constipation is also expected. And one more thing is difficulty in urinating. This becomes important in patients whoever is a known case of BPH. benign prostatic hyperplasia. What happens in this patient? If a patient is already a known case of BPH, what happens? Already he is having difficulty in micturition, in emptying his bladder, right? He complains usual as I'm going for 6 to 8 times more frequent than usual, right? If we give this agent TCS, urination will become more difficult, micturition become more difficult. He may visit the casualty with a complaint of lower abdomen discomfort plus anuria. Lower abdominal discomfort plus anuria. It might be the chief complaint in a BPH patient who starts this TCS. And alpha 1 blockade. What happens when alpha 1 receptors are blocked? We can expect postural hypotension. What happens in postural hypotension? Yes, patient can't stand for a longer time. He experiences giddiness, or he may faint also. Okay, and sedation is also expected when alpha 1 blockers, alpha 1 receptors is blocked. In MCQs, the question which we can expect is a patient who started these TCAs just 10 days back came to the casualty with a complaint of weakness in early morning hours and complaint of one episode of fainting. One episode of fainting usually within 1 week or 10 days of within 1 week or 10 days of TCA therapy initiation. When these TCAs are started, we can expect this complaint. Then immediately we can think, yes, it is because of alpha 1 blockade. Or in the question they may mask that TCA. He started some unknown antidepressant drug. Within 10 days patient fainted. We can expect that it may be due to alpha 1 blockade, which is causing hypotension, orthostatic hypotension. Within 1 week of therapy start, within 1 week of therapy initiation, it is the reason for fainting in a patient. What happens when these serotonin type 2A receptors are blocked? Yes, it is a side effect which we can see in antipsychotic drugs also. There will be weight gain in patient. What happens when dopamine receptors are blocked? Yes, we can see extrapyramidal symptoms like tardive dyskinesias. All these things are given in MCQs as a clinical based question. A patient started antidepressant therapy, unknown drug, and these are the side effects noticed in a patient. What might be the drug causing these side effects? Then the drug causing these side effects will be TCAs. One of the drugs among the list of TCAs will be present in the four options as one of the four options. Then we can opt the answer as TCAs. Okay. And what are the toxic effects which we can expect due to quinidine-like effects on the heart? It is very important toxic effect, very popular MCQ in exams. Actually, TCS has a quinidine-like property while it acts on heart. Okay, while it acts on heart, it causes arrhythmias. How these arrhythmias are important? If this is of more dose than recommended, that is patient may consume it with suicidal tendency, or unknowingly patient by mistake might have consumed 2 doses or 3 tablets because he might have forgot that he has taken medication. He might have taken extra dose unknowingly. Then it causes life threatening arrhythmias. Okay, in exam, in MCQs, they will provide us a clinical based question. Clinical picture will be given that a male patient of middle age or someone who is started antidepressant therapy of unknown drug came to the casualty with a complaint of many clinical picture will be there. One word we can notice is lethargic will be the patient might be lethargic, and we can see the clinical picture as patient may be having dilated pupils. Yes, mydriasis is seen, and we should think of mydriasis because of some antimuscarinic thing which is going in the body of the patient. And another antimuscarinic property we can see is there will be increase in heart rate. All these are mentioned in the clinical picture, antimuscarinic property, and they will give us more and more details that there will be hypotension in a patient, which gives us a hint of yes, due to alpha 1 blockade, and respiratory rate will be decreased. Okay, and main clinical main classical feature which we can see is they'll mention clearly about the ECG there is a wide QRS complex in this patient. Okay, but the same patient, if it is consumed in high amount of toxic doses, we call it as severe poisoning. In the severe poisoning cases, we can expect variable degrees of AV block. That AV block might be of any degree. Okay, but the common point which we should observe here is there will be bradycardia, not tachycardia, bradycardia. What does we infer from this? We should remember that it is of poor prognosis. Okay, so what will be the treatment of choice for this condition? Treatment of choice of this condition is first treatment of choice is, that is first drug of choice will be give him immediately injection of sodium bicarbonate, and second choice will be antiarrhythmic. In the options, if they give you antiarrhythmic agent, go for antiarrhythmic agent as correct answer. Okay, but along with antiarrhythmics, if they give you injection of sodium bicarbonate, it will be the more appropriate answer. It is the first choice, and then second line is antiarrhythmic. So don't be confused when both the options are given. And one more thing question will be expected is, for any depression patient, whoever is given a TCA agent, this TCA agent should be given as limited supply. That is, patient should not be provided with 10 sheets of tablet. He will be provided of only limited number of sheet, only one sheet or two sheet. Okay, limited supply should be given available to the patient, because patient should not consume them by mistake or even due to suicidal tendency. Even the question will be, patient is given limited supply, what is the main reason? The main reason is not any other side effect. Main reason is, which we should bother about is, yes, life threatening arrhythmias. This is the main reason. If they give you any other reason like orthostatic hypotension, no, life threatening arrhythmias is the main reason. That is why we give them limited supply, which is available to the patient in his bedside on his room. Coming to the dose adjustment, when do we adjust the dose? To adjust the dose, there are two types of situations we can see based upon the drug concentration present in the plasma, and there is another scenario where we don't bother about the drug concentration in the plasma. These are two different types of situation. When do we use which one? When do we titrate the dose based upon the drug concentration but not upon any other thing? When we go with this feature is to avoid toxicity in slow metabolizers. Okay, in these patients dose will be decreased, in whom people with poor metabolism of TCA drug, we call them are poor metabolizers. In these patients we see the drug concentration in the plasma, and then we will decrease the dose based upon the pharmacogenetic study. And when do we do not consider the plasma drug concentration? We do not consider drug concentration in plasma during clinical response assessment. Okay, what does this mean? In clinical response assessment, we titrate the dose, that is, we can increase the dose or we may decrease the dose based upon only upon clinical response, not on the concentration of the drug in the plasma. Understood? From this, we can conclude the short discussion on TCAs. And one interesting question is present here. You can answer to this question in the comment box below. Okay, so which receptor blockage is responsible for fainting initial 10 days of TCA therapy initiation? And thank you for watching, and please subscribe to this channel. And if you find the information in this video is useful to you, helpful to you in understanding your concept, like this video and share this video to your peer groups. Okay, and see you soon in next video regarding the continuation of antidepressant topic. Okay, thank you for watching. Meet you in next video.